Hello everybody, David Wilson here, the doctor from Dr. Stem Cells, and in this video we're going to look at the article, again the same one as we've been looking at before, about PRP versus corticosteroids. So this is the American Academy of Orthopedic Surgeons. This is the same paper that we've already been looking at, and if we look at this, here we are, we're at the bottom of page 6. However, just to see, this is the American Academy of Orthopedic Surgeons Technology Overview PRP for knee osteoarthritis. So if we go back here to page 6, there are a few things we want to talk about in this video, but I feel like it would be worthwhile first and foremost to talk about how we actually heal when we heal. And so we're going to begin by looking actually at a different article, this one. This is a paper that was published in 2013 by Hani Saino and Satya Prakash. Now, this, as you can see here, these gentlemen work in Canada in the Department of Plastic Surgery, and so they've been looking at how we heal. Let's have a quick glance over this article. There are some very interesting findings here. This will help us to understand then how the body heals and hopefully put into perspective why PRP works and why corticosteroids work. Now, this video, we're going to do a standalone, more in-depth of this, but as we look at this, we can see that here we say more than 2 million burn cases and 7 million chronic skin ulcers caused by pressure, arterial venous insufficiency, and diabetes mellitus each year in the United States alone affected by abnormal wound healing. Massive costs, $9 billion in an attempt to reduce the major disability and consequences, including death of such severe skin injury. But this is the page we want to actually take a look at. Now I'm going to turn this sideways. Let's take a look at this one. So the talk we want to have today is regarding what happens when we heal. Now, we're going to have to go a little bit back forward in terms of rotating this this page, because on the one hand we have it sideways, and all the names are going down the page. The timeline really is why I wanted to bring this up. First, you get an injury, so injury time 0. Then, and they have it over here, injury. At the time of injury, you get the clotting cascade. That happens because of the injury to the tissues. That happens that the blood will follow the normal clotting cascade unless someone has one of these hemophiliac or similar bleeding disorders, or if you're on medicines which stop that, but we'll talk about that a little bit later on. And as we progress down through the inflammatory phase, then the proliferative phase, and then the remodeling phase, they happen between 3 days, 1 week, and then several weeks later on. Now, the reason this is interesting is that as we look at the different sources of injury here in the middle column, we can see which growth factors the body releases and what happens there. So of most interest for this particular talk are thromboxane A2 and prostaglandin F2 alpha. The prostaglandins, there are a whole list of them. They have a lot to do with how the body immediately responds to injury, and they will encourage the body to enter the inflammatory stage and the inflammatory phase, so you get a development of pain, redness, swelling around the injury site, and that's actually all to increase the ability of the body to send in more nutrients. You get vasodilatation to allow blood to come to the area that's in adjacent tissue, and you get vasoconstriction of the tissue which is actually needing to re-heal. The reason I bring this up is because if we now go back to our summary of corticosteroids, let's just swap here to this one. There were 6 high-quality studies looked at, and corticosteroids, they specifically affect patients at this stage. So corticosteroids will stop the development of prostaglandins in particular. And in so doing, they stop inflammation in its tracks. So if you have someone who has a chronic inflammatory pain generator, so they have pain because of inflammation, then this kind of treatment is going to give exceptionally good results in terms of their short-term outlook, because the body will not be able to generate those. You're going to have reduction in swelling, you're going to have reduction in the pain generators and in the redness and in the heat and all of the issue around the tissues which might be causing some pain in the patient. So there were 6 high-quality studies that looked at corticosteroid into the joint against PRP. They're listed here, as you can see, and 2 moderate quality studies for PRP versus corticosteroid for patients with osteoarthritis of the knee. The 6 high-quality studies valued outcomes of a total of 359 patients. So again, we could divide that by 6. You're talking about 60 patients in each group, in each paper that is, And PRP showed inconsistent outcomes when compared to corticosteroids for visual analog score pain, statistically significant improvement in 4 studies, no statistical difference in outcomes of 3 studies, and statistically worse outcomes in 1 study. 3 studies analysing WOMAC patients' reported outcome after injection with either PRP or corticosteroid had varied results. 1 study identified no statistically significant difference from baseline at 6 months after injection. Another high-quality study compared triple and single-dose PRP to steroid at 6 months after injection reported the PRP cohorts had a greater improvement overall, and 1 moderate quality study compared PRP as well as hyaluronic acid and demonstrated a significant difference in the PRP group in the total WOMAC score at 12 months. Of the studies included in this comparison, only 7 recorded the BMI of the patients, and of those 4 recorded BMI over 30, which is into obese territory. Current literature demonstrates that joint arthroplasty patients tend to be obese, and we can look at that. Additionally, 25% of the studies included severe grade 4 degenerative joint disease, a class not presently recommended for administration of biological therapies. That's correct. These factors may influence the generalizability of the findings. In summary, when PRP was compared to corticosteroid injection, there were varied results in patients and patient-reported outcome measures. Further randomized control trials are needed to optimize and standardize PRP preparations with advanced imaging at longer-term follow-up to determine if there are any sustained effects. So, back to our healing cascade. Because corticosteroids are such potent inducers of anti-inflammatory effect, they are so very good at reducing the amount of inflammation that's visible in a tissue. They can help to take down swelling. That reduces in turn the pressure that's experienced by the cells and the nerves in the tissue, and they can reduce the actual swelling of the tissue itself, and they can also increase function and movement then. So first of all, the most important takeaway here is that corticosteroids versus PRP, they give maybe better, maybe the same, maybe worse, but it seems to be a kind of a balance where there might be an effect or there might not, we're not sure. But what we do know for many years now is that corticosteroids have an effect, and we know why they work. We know the basic fundamentals of why they can give people an improvement. And so what's worthy of discussion here then is this point, this perspective that a patient with corticosteroid may have, let's say, similar outcomes if they get PRP. So the next question then becomes, well, is there any reason to choose PRP over corticosteroid or vice versa? Corticosteroid are going to give an immediate relief at this early stage. So when we look at our diagram here, and we see this, we have the clotting cascade. That's good. We want people to have clotting if they have an open wound. But when we get down now a few lines and we get to thromboxane and prostaglandin development, this is where your steroid will have a definite effect. It will stop people having that immediate painful stiffness, loss of function. However, there is a growing body of evidence which also, because you inhibit these sections here up at the top of this, you can also inhibit the actual proliferative phase. You can inhibit the progression of the body from early adoption of pain and swelling and all the issues that you get from a short-term injury. That can actually lead to a worse outcome for patients who have received corticosteroids simply because it inhibits the rest of the pathway. By comparison, a PRP will be an injection which actually gives concentrated doses of these factors, prostaglandins, thromboxane, prostaglandin development, and actually platelets are known to contain a lot of. So if we look here in this line, platelet, where do all these complements come from? Well, they come from the platelets. So steroids inhibit platelet function. PRP is concentrated platelets, which will therefore have a concentrated effect on the healing cascade. So this explains why at the longer term outcome we're starting to see some evidence suggesting that PRP is superior to steroids simply because the steroid injection will actually wear off over time, whereas the PRP injection will encourage this healing process to take place over weeks to months. As we wait and we watch and we observe the patient with corticosteroids, you're going to have effect while the steroid is in a pharmaceutical or pharmacological dose. We're going to have a drop off of effect as that dose is taken away and as the body digests and removes it. And you're going to have finally then ending up with probably similar outcome to where you started. In the PRP group, we're going to see an increase in inflammation in the early stages. So the first 2 to 3 days, you're going to have more prostaglandins, you're going to have more pain, more stiffness in many cases for 2 to 3 days after injection, after which point you will then start to have the healing cascade as normal. This also would then lift the important point that if a patient has diabetes or if they have other inhibitory factors, they're taking non-steroidal anti-inflammatories or steroids, that's going to give them a worse result from PRP simply because the platelets themselves will be inhibited by those drugs. The takeaway here then is that for patients who have joint arthritis or who would be candidates for a corticosteroid injection, I feel that this is good evidence to say that, well, PRP seems to be about as good as corticosteroid if you look at the evidence as a whole. Some evidence says it's better, some says it's worse. I think if we say, okay, it's about the same, that's pretty good. Side effect wise, you do not have the same side effect profile from PRP as you do with steroid, simply because a steroid injection contains the risk that people will actually have distant systemic effects from the steroid. Pull up your local formulary, the BNF or whatever you use, and take a look at the risks and side effects that are listed there for steroid injection. You're going to find that people can have activation of latent diabetes, they can have increased incidence of gastric and gastrointestinal bleeding, they can have other problems like increasing the rate of development of things like glaucoma and other diseases. I would say that corticosteroids have their inherent risks. Now, they're not very likely to happen, but it is a risk and it should be discussed with your patient. Whereas PRP, because it's an autologous product from the patient for the patient, the only real risks there then are the actual administration during the injection and the immediate period afterwards. I think this is an interesting topic. We're going to do a more in-depth dive of the healing cascade, so look out for that video in the future. But for now, this video was a quick summary of my personal feelings on this report about PRP versus corticosteroids. I hope you all have a nice day. With questions, any issues, any comments, leave them down below and we'll try and respond to them later.